What we're going to talk about now is the removal of relapse factors that can compromise long-term case stability. Here's a list of just some of the relapse factors you may deal with in an orthodontic case. Habits such as thumb sucking or tongue thrusting can have a negative effect on long-term stability. Basically, thumb versus teeth, thumb wins. Tongue versus teeth, tongue wins. You must stop the habit in order to prevent relapse of the case. Frenums can be a big factor in the relapse of space closure cases. Removing the frenum in this situation can help prevent relapse. Rotated teeth are more prone to relapse, so I will show you how we remove that relapse factor. One factor that just isn't mentioned enough in my opinion is the removal of heavy incisal interferences that can lead to relapse. I will show you how we remove all of these relapse factors to help ensure good long-term case stability. Tongue thrusting can cause open bite cases or spacing cases to relapse. You always want to check for tongue thrusting in a case. Simply tell the patient to bite down and swallow 5 or 6 times in a row and see if the pink monster is shooting through the teeth. Here's a video that shows a patient with a tongue thrust. In order to help with a tongue thrusting patient, we place a myofunctional tongue bead in addition to braces. Now, this appliance will not work as a standalone measure, but it must be used in conjunction with braces. After a few months of wear, the tongue starts to move up and back instead of shooting forward. Now, many doctors say they haven't had success with this appliance, but I think one of the reasons I've had such good success with it is that once the patient's tongue repeatedly goes up and back when they swallow, I leave the appliance in for 90 more days. My wife is actually a speech pathologist whose area of expertise is swallowing disorders. She's even published on it, and she has been very impressed with our results when we use the myofunctional tongue bead in addition to the braces. Again, frenums can be a big factor in the relapse of space closure cases. In a case like this, removing the frenum can help prevent relapse, preventing those upper centrals from wanting to spread back open. Rotated teeth. Any anterior tooth that is rotated more than, say, 20 degrees is a candidate for a circumferential fiberotomy to aid in long-term stability. You simply numb the patient, take a 15C blade down through the sulcus until you hit the crest of the bone, and work your way all the way around the tooth. Now here's a video on fiberotomies. Again, you simply numb up the patient, take that 15C blade down through the sulcus until you hit the crest of the bone, and just work your way around all the teeth. What you are essentially doing is severing the supracrestal fibers. They will regrow in a straight direction and act like a retentive cuff around the neck of the tooth. There is research on these, and I can say anecdotally that I have had far fewer issues retaining rotated teeth once I started doing more fiberotomies. One factor that just isn't mentioned enough in my opinion is the removal of heavy incisal interferences that can lead to relapse. Let's say you treated a case that had a midline diastema. The diastema closed nicely, but when the case was done, it was finished with a heavy incisal interference. What can happen is that heavy incisal interference can cause a forward movement of the upper incisors, which in turn reopens the midline diastema. Now let's say you treated a case that had lower anterior crowding. You got everything aligned nicely, but the case finished with a heavy incisal interference. What can happen is that heavy incisal interference can cause a lingual movement of the lower incisors, which causes them to return to a crowded condition. You want to make sure you remove any heavy incisal interferences from a case to help reduce the chance for occlusal-related relapse. Now, if you remove these relapse factors, you will help increase your chance for good long-term stability. Here is a case that required a lot of tooth movement and a lot of rotation correction. These cases can sometimes be a challenge to retain. Here we are 6 years later. There were no heavy incisal interferences, and we did fiberotomies on the very rotated teeth. She used only removable retention on the lower and had only removable retention on the upper for about 2 years after bracket removal. She requested a fixed retainer at that point since she had a dream where she looked in the bathroom mirror and her teeth were crowded like they were in the before picture. We all had a good laugh about that and then put in a 3x3 fixed upper retainer for her. Here's a case on an older teenage boy. Now, teenage boys are the worst about retainer wear, followed very closely by teenage girls. You can see he needs a lot of tooth movement and bite opening. Here we are over 5 years later. You can see the case is still stable even with just removable retention. Fixed retainers are not an absolute requirement when you remove the relapse factors and have even moderately good retainer wear from your patient. In this case, we opened the deep bite, which removed the heavy incisal interferences. That was a key removal of that relapse factor. Here's a spacing case with over 5 years of follow-up stability. We removed the relapse factors of the deep bite causing incisal interferences, the frenum, and fiberotomies were done on the very rotated teeth. Again, you can see this patient had removable retention only. Here's another case with over 11 years of follow-up stability. This patient was not great with wearing her retainer, yet you can still see we got good stability on this case. The removal of these relapse factors plus a good retainer wear protocol will help you be very successful with long-term stability in your office. To make sure you don't miss any of our Powerprox pointers, please subscribe at 6monthbraces.com/orthotips. To learn more about our live seminars for Powerprox 6-month braces, please visit 6monthbraces.com/live seminars. To learn more about our unlimited case support and online seminars, please visit 6monthbraces.com/online seminars. If you prefer to call us, our phone number is 440-646-1000. To learn more about our laboratory services for Powerprox 6-month braces, which include digital bracket placement, 3D printed indirect bracket bonding trays, digital case setups and treatment simulation images so you and your patients can both see the case results before you even start, IPR guides so you know the exact amount and location of any IPR that you may need, and a lot more, please visit 6monthbraces.com/PowerproxLab.